Right, okay, good morning, ladies and gentlemen. I think it's time we kicked off. It's 9:10. We're a little bit late. There will no doubt be people staggering in because of the late registration, and it's the first session of the day, etc. So, welcome to the masterclass in atrial fibrillation. A few housekeeping notes. Session is going to be filmed. We've got plenty of time for Q&A, questions, answers, discussion at the end of each session, so please feel free to ask any questions you may have of the presenters and of each other. And let's try and make this as interactive as we can. There should probably be another at least 20 to 30 people coming over the next half hour or so. We'll start the first session, which is about atrial fibrillation in context. 3 esteemed speakers, and Chris will introduce our first speaker.
Thank you very much. Good morning. I'd like to introduce Derek Connelly, who's Honorary Clinical Associate Professor at the Institute of Cardiovascular and Medical Sciences at the University of Glasgow, Consultant Cardiologist and formerly President of Heart Rhythm UK. For those who aren't from the UK, I just wanted to mention that commissioning is the process by which reimbursement is arranged for cardiac surgery. Thank you, Derek.
Well, thank you very much, and thank you for the welcome here. It's great to see such a full hall at this time in the morning. We'll see how the rest of the session goes once the warm-up is finished. I'm talking mainly about the incidence and prevalence of atrial fibrillation to introduce the session today. And in the interest of time, let me skip over 1 or 2 of the slides as we go through them. This slide is taken from the European Society of Cardiology guidelines, which came out about 3.5 years ago, and it's just to remind us that atrial fibrillation is associated with a wide number of cardiac conditions and other risk factors. Top of the list is hypertension. Most of our patients with AF have a history of hypertension, or at least were hypertensive before they went into atrial fibrillation, and it's closely followed by heart failure, valvular heart disease, cardiomyopathies, congenital conditions. Coronary artery disease is not top of the list, but it's certainly in there. And of course, we shouldn't forget that we should always check thyroid function tests in patients with atrial fibrillation, and there are other factors that contribute as well. As far as the epidemiology of atrial fibrillation goes, there have been a number of studies over the last 10 to 20 years. We know that AF is the most common sustained arrhythmia that we come across, and the old-fashioned estimates that we'll update a little bit over the next few minutes is that the prevalence in the population is about 1% overall, and over the age of 70 it's estimated to be at least 5%, though that may be an underestimate. It's an independent risk factor for stroke, and in the Birmingham Study it increases the risk of stroke more than 5-fold, and the risk ratio is even higher with patients with hypertension, mitral stenosis and heart failure. It's particularly responsible for a lot of strokes in the elderly. In patients over the age of 80, about 25% of strokes are associated with atrial fibrillation. And these tend to be quite severe strokes as well. The disability and the mortality from stroke is higher with AF patients than with other patients, presumably because it's a large embolus travelling from the heart rather than a small dissection of a vessel in the cerebral circulation. So large number of strokes, large morbidity and mortality from those strokes. And overall, atrial fibrillation is said to be associated with at least a 50% increase in mortality over 5 to 10 years, perhaps in some groups up to a 90% excess mortality. And these are data mainly from the Birmingham Study and from the Paisley Study here in Scotland. If we look at the Birmingham Study, they found that atrial fibrillation was more common in males, more common in patients with hypertension and diabetes, more common in female smokers, much more common in patients with heart failure and valve disease, and after myocardial infarction, more common in males, for what it's worth. If we look at the Paisley Study, which is a study done in the 1970s, not far from here in the west of Scotland, where they did a number of epidemiological assessments of middle-aged men and women aged 45 to 64 in the mid-70s and followed them up. The prevalence of atrial fibrillation at that time was 6.5 per thousand in a relatively young stroke middle-aged population, and the incidence was as shown. In Framingham, it was shown that the prevalence of AF doubled with each advancing decade of age, and these numbers may actually be an underestimate if we look at the more recent data that we're just coming on to. This is a study of Air Force recruits in Canada, followed for 40 years, published by Andrew Cran from London, Ontario, and they found once again that the incidence and the prevalence of atrial fibrillation rose with age from very low numbers under the age of 50 to approximately 1% new incidence per 100 9.7 per thousand, so about 1% per year increase in rate after the age of 70. And of course the risk was increased with all these factors that we're familiar with. This is slightly more recent data from California, looking at the prevalence of atrial fibrillation related to age. So we see that in patients in their early 70s, the prevalence of atrial fibrillation is about 3 to 5% in this study. And once we look at the patients over the age of 80, it's closer to 10% or higher. And if we look at the Birmingham study, where they introduced a screening program for atrial fibrillation, they found even more patients when they started randomizing patients to either ECG screening, or what was just as effective was taking the pulse of elderly patients attending the clinic and doing ECGs in those patients. This was carried out in primary care in Birmingham, and their figures are, if anything, slightly higher prevalence, around 4 to 6% at the age of 65 to 74, around 10%, 10 to 12% in the patients 75 to 84, and 14 to 16% in the over 85. So the harder you look for atrial fibrillation, the more you find of it. And in this Birmingham study, which is one of the most up-to-date ones, we're talking about certainly a more than 10% incidence over the age of 80. And atrial fibrillation is not a benign condition. These are quite complicated graphs. This graph here is a so-called middle-aged population. I find it very awkward talking about this because I turned 55 yesterday, and it's slightly worrying to think that if I get atrial fibrillation, I will have a 15% one-year mortality. These curves, the lower curves are women with sinus rhythm, men with sinus rhythm, and women and men with AF. And here's the same in the age 75 plus group, females and males in sinus rhythm, females and males with AF. This is a 5-year time span, this is 10 years. And you notice a number of things. First of all, atrial fibrillation is associated with a higher mortality. Secondly, the increase in mortality happens very early on, at least in this study, within the first 3 to 6 months or so. And thirdly, the advantage of being female disappears in atrial fibrillation, that females with AF have just as high a mortality as the males in both the middle-aged and elderly groups, compared to the sinus rhythm groups where the females are doing better than the males. So males are more likely to get atrial fibrillation, but females are perhaps more likely to die as a consequence of, or die in association with atrial fibrillation. And being female is an additional risk factor for thromboembolic complications, etc. This is similar data from the Renfrew-Paisley study done a few miles west of here, over a 20-year follow-up of middle-aged patients who were found to have atrial fibrillation. We see that the females and males had similar mortality, and it was significantly higher mortality than in those patients without AF. So the women did better than the men if they didn't have atrial fibrillation, but if they had atrial fibrillation, female mortality was as bad as male mortality, at least in the west of Scotland. And the numbers are going up. If we look at where we are now, this is an American study. Their population is 300 million, and it's estimated that at the present time there are about 2.5 million Americans with atrial fibrillation. If we extrapolate that to our population in the UK of about 60 million, we're talking about 500,000 people with AF. If we fast forward 40 years, to when I'll be in my mid-80s, it's estimated that there will be 5 million Americans with AF, and in the United Kingdom, if our kingdom is still united, as I very much hope it is, there'll be about 1 million people in the UK with atrial fibrillation. So the numbers will go up and up according to these estimates. I'll skip over this primary care study. It's a study looking at atrial fibrillation prevalence in a number of GP practices in the west of Scotland, so I won't spend too much time on that, except to mention that for general practitioners, the burden of atrial fibrillation, the number of consultations with atrial fibrillation, is just about as high as the number of consultations with angina for both males and females. So it's something that GPs want to find out more about, because they're seeing a lot of patients coming to their clinics, coming to their health centres and their surgeries with atrial fibrillation, and there's perhaps not been enough education on AF in general practice. Now, all these studies rely on identification of patients who are in atrial fibrillation when they see their doctor. So it's mainly detection of persistent atrial fibrillation by pulse checks and ECG recording. The data on the incidence or the prevalence of paroxysmal atrial fibrillation is even more nebulous and more difficult to obtain, even in symptomatic patients, and it depends on how hard you look for it as well. If we look at studies, for example, of patients who've had ablations for atrial fibrillation and who just happen to have a pacemaker in, we find that if you interrogate the pacemaker frequently enough, you'll find that these patients who've had so-called curative ablation actually have quite a high number of episodes of atrial fibrillation, many of which are silent. So you can't ignore silent atrial fibrillation, and the more you look for atrial fibrillation, the more you find. There's a lot of emphasis on early detection of atrial fibrillation. The Arrhythmia Alliance has run a pulse check campaign. The general practitioners are encouraged to be looking for atrial fibrillation and using tools such as the GRASP AF system to ensure that patients are on the correct treatment for atrial fibrillation. And when we had a consensus conference in this city 2 years ago, it was decided that we should certainly seriously consider screening for atrial fibrillation in elderly patients. And the most cost-effective way of screening in primary care was opportunistic screening of people over the age of 65 by checking the pulse and followed as soon as practical by a 12-lead ECG for elderly patients with an irregular pulse. It's a high cost, sorry, I missed a slide there. It's a high cost to society, a high cost to the National Health Service. This is a study by Simon Stewart working with John McMurray in Glasgow a few years ago. They estimated that in 1995 there were 500,000 patients in the UK with AF, and the direct cost of healthcare was, as quoted here, about £250 million, and by 2000 the cost had risen to more than £500 million, and it's likely that it's gone up further over the past 10 to 15 years. And if you factor in the cost of strokes after atrial fibrillation, it gets higher still and will continue to rise. So stroke and thromboembolism, heart failure, impaired quality of life are all contributing to the burden of atrial fibrillation. I'm not going to say much about commissioning, perhaps leave that to discussion. I don't know much about the commissioning system in England and Wales, but there are other people in the room who might know more than I do. For Scotland, commissioning tends to be somewhat haphazard. You're very lucky if you're running a national service, such as the Advanced Heart Failure Service, dealing with VADs and transplants and so on, or adult congenital heart disease, which is centrally funded, and they're looking for things to spend money on for these services. For anything else, where it's commissioned regionally or locally, in Scotland it's very much collaboration rather than competition, which means we have to discuss around a table what the money is for and what we can spend things on, and we're continually told there's no new money. New services take a long time to be approved, and money has to be moved from one service to another. So if we want to introduce a new service in Scotland, the first thing we're asked by our managers is, how much will it cost? Where can we save the money, not where can they save the money? Will it result in savings in the future? Are there waiting list implications? Will doing this shorten your waiting list? Will doing this procedure prevent someone from needing something else down the line? Will it allow you to do 4 ablations a day rather than 3, or 3 rather than 2? And way down the list, will it be beneficial for patients? So atrial fibrillation is common, certainly more than 1% prevalence overall, and probably more than 10% in patients over the age of 80. It's increasing in prevalence, and the numbers will double over the next 30 years or so. It's potentially lethal, especially in the first few months after diagnosis. It's important to think about early institution of treatment such as anticoagulants. It's detectable, particularly in elderly patients, if we perform opportunistic pulse screening in general practice, and it's treatable. Thank you very much.